Welcome to Balanced Care Conversations with Equilibrio Home Health, the podcast that bridges the gap between innovative healthcare technology and compassionate home care. In each episode, we dive deep into the transformative world of healthcare solutions, exploring everything from physical therapy to the latest developments in skilled home healthcare. Join us as we engage with industry experts, healthcare professionals, and technology pioneers who are reshaping the future of home-based care. Whether you're a healthcare provider, caregiver, or someone passionate about advancing healthcare solutions, this podcast delivers valuable insights, practical strategies, and inspiring discussions that help create more balanced, effective care environments. Subscribe now on Spotify, Apple Podcasts, Amazon Music, or your favorite podcast platform to stay at the forefront of healthcare innovation.
Welcome to another great edition of our Equilibrio Balance podcast series. Wanted to welcome all of our followers, supporters, and people that definitely like to learn about more of the skilled home health industry today, as we are with one of our student DPTs, as Equilibrio Home Health has a very great program with University of St. Augustine Health Science DPT program. It's based out of Miami. We do have some students coming from the University of St. Augustine campus from St. Augustine, Florida as well. And we even have a student coming from the San Diego campus out in California as well later in May. So we've got a wide variety of relationships with campuses through the University of St. Augustine. And today's podcast, we are really going to be getting to know one of our recent students that is finishing up his first internship. His name is Nahshon Robinson, and he's got more of an interest in working with some Parkinson's patients. In fact, his in-service that he's required to do from his university revolves around Parkinson's patients and what types of Parkinson's patients and treatments. So I'm going to introduce everyone to Nahshon Robinson, to give a little background on himself and what brought him here to Equilibrio to do his first internship, and what his thoughts are on skilled home health, for us.
Yeah, thanks, Matt. So my name's Nahshon. I'm a student physical therapist with the University of St. Augustine. So what brought me here was just understanding that, one, it was a requirement, too, for my inpatient in-service, inpatient rehab type of setting. So that includes home health. And I've been at St. Augustine for 3 years now, going on 3 years. So like Matt said earlier, it's my first rotation. And what brought me here, it was I had some family that lives in Yorktown. Mm-hmm. So being able to come over here and being able to be in this Virginia Beach area has really opened my eyes to see what patients I can work with. People specifically that have like Parkinson's disease or dementia. So it really has opened my eyes to see these populations and how we're able to work with them. And Equilibrio has showed me a lot.
That's great. Working with a diverse population in home health, we work with, as you can know so far with your internship, a wide variety of patients. So it's not just cookie cutter orthopedic patients that are in outpatient therapy with ankle sprains, shoulder sprains, rotator cuff issues, right, knee, hip issues that are more muscular or sprain type origins. We're working with patients that may have dementia, Alzheimer's, Parkinson's, right, major neurological issues, strokes, different types of cerebral vascular accidents, traumatic brain injuries, fractures, you name it, diabetic conditions, neuropathy. Yeah. So it's pretty much anything under the sun. We even have a few patients with quadriplegic cerebral palsy.
Yeah, that's what I've heard too.
So it is a wide variety. What would you say are some positives and negatives that you see in home health, in skilled home health, since you've been here for the past 5 weeks, from the typical day in home health so far with your experience?
Understanding too that home health can be pretty flexible as well.
Right.
Just understanding your guys' schedule. When I first got here, I was, I'm so used to, I worked in an outpatient setting for a little while. So seeing how it was so, patient after patient, hour after hour, it was really overly structured. Being in home health, I see how a little bit more flexible you guys are, and then also understanding too, but you still have your schedule, but being able to see your patients within the timely manner, and then being flexible for the patient. It revolves around the patient, and what I've noticed is that you guys have been able to provide, and we've been able to provide, myself included, great care to these patients, and they've all benefited. A lot of them love you guys, love us. So it's been really helpful to see how they've taken that information in what we've given them. Patient education, we always encourage constantly educating them and letting them know what they can do to take care of themselves and how we can take care of them. And it's been really helpful to see how you guys shaped me while I've been here. So,
that's great.
Yeah, like I said,
it's full circle.
Yeah.
Yeah. I mean, you've helped us tremendously too with your insights and your passion, and just when you're talking with patients, I can tell you're really looking to create that emotional bond and trust. That's something you really can't teach. It's more empathy and just putting aside their healthcare issues and just looking to find a common interest or bond, and then getting into what's going on and then pulling from your knowledge. But I always say in home health, you can't really be effective in this industry, really in any healthcare industry, but especially in home health, because you're going into their domain. It's their home. It's not our practice. It's not our brick and mortar building for outpatient therapy. We are taking our tools, our knowledge, our expertise to their front door, wherever that may be: assisted living, group homes, their home. Could be a big home, could be a small home. It could be patients from all walks of life, and some of them very meager conditions where they don't have much, and they're looking for some hope. They're looking for someone to help them. And I think you definitely exude that when you go in and help make them understand, that it is going to get better. We just have to take certain steps and getting them on the right track. And we can improve their living situation because we have medical social work services that can do that, or even in some rare circumstances, APS, Adult Protective Services, can help patients in our industry.
Yeah, and I've noticed that too. A lot of the patients that we've looked at, and worked with, understanding the living conditions that they may be in, it's sensitive too. Some people don't want you to just walk in their houses, right? So that's why we call ahead of time, asking for consent to work with them. And a lot of the patients that we have seen, where understanding that some people live in really, really nice neighborhoods and some people live in decent neighborhoods, that, we want to make sure we encourage safety within the house, right? So we walk in, introducing ourselves, and bring that enthusiasm and that empathy to allow for them to feel so they can trust us, building that rapport. So what I've noticed being here is that they've really taken a liking to Equilibrio, and they really respect how well we treat them.
That's exactly what we want to get, is every patient is treated uniquely, case by case basis. And we're not approaching our patients from a cookie cutter standpoint. We have certain methodologies with assessing patients with our Balance in Life program and our specialty programs, where we do want clinicians to have a uniform approach of looking at certain systems of balance to assess why they might be dizzy or falling. That is something that it could be systematic to our company only, but the caring and how we approach, setting up a plan of care, or prioritizing things from balance to socioeconomic needs, things like that. It just depends on the patient, because you can't help somebody until you meet their rudimentary needs at home. And they have to have a good environment with family supporting them, and a safe environment. If that's not there, we help get them into that environment, or we start the conversations. In addition to helping them physically with what they need, but sometimes there has to be a little less of the therapy part, physical therapy, and we got to put more of our social work hats on.
Yeah, that's right.
Which is cool. So getting into this third topic that I wanted to ask you, school versus real world practice. As you are a student, and from what you've known in school, what's been the biggest difference between what you've learned in school and what you're seeing in the field?
That's a loaded question. So basically with school, it's a lot of, we're really taught to basically answer the questions, right? So we take our tests, and we're really molded on how to take the test. And when you're in the real world setting, it's not like that. I've seen patients, we talked about my in-service coming up regarding Parkinson's disease, and me seeing people that have Parkinson's disease and potentially dementia and other comorbidities, it's really been eye-opening to see it's not just the textbook way, right? There's going to be other ways that we have to approach the patient to allow for a successful treatment.
Right.
So definitely the real world setting is more eye-opening compared to the school.
Yeah.
And school does set you up for success as well. Understanding too, they really drive into our heads that we need to at least understand the diagnosis, what the risk factors are, and how to approach the diagnosis or treatment in general. But the main thing is, though, you can't just use that. There has to be other ways to treat the patient. And that's not taught so much in school.
In school, right.
Mm-hmm.
So sometimes you feel like you're getting the toolbox of things you need to use in practice and theory in the home setting or any setting. Just clinically, first time you ever see a patient, you're just there to help them.
Yeah.
But you don't get the intangibles like in school. They'll tell you how to treat this disease process or that or this issue. But once you see that patient in their own setting, it's a little different, right?
Yeah, and I noticed too, like we've talked about this a couple times before off air, that at school we're not really taught so much about home health, and I think that is one thing that I wish I had a lot more of or a better understanding of home health prior to coming.
Right.
But that's what internships are for, exposing you to new settings that allow you to gain this knowledge that you wouldn't have had in schools. But understanding that school doesn't teach you they'll tell you about each setting, particularly like outpatient orthopedics or inpatient rehab, skilled nursing facilities. Those are all great settings. However, I don't think the home health setting has given enough, has been introduced enough, which coming here, it allows me to see what I can learn, right? So understanding OASIS documentation, we talk about it. I didn't learn about it too much prior to coming here,
right.
But seeing how in depth you have to be with the patient, with not only the documentation but with the patient, it's extraordinary. So basically, like I said, the real world experience compared to school is much different, and that's why I enjoy being at this internship, because it's allowed me to see what it is that can make me a better future clinician.
Wow, that's really impactful, and I'm great. The listening audience will really pull from that, especially other students that listen to this. They'll really gain a lot of insight there.
Right.
And then anyone else that, is just a healthcare professional or just listening, it's just food for thought, basically. Our fourth question I wanted to touch on, what about a moment that clicked? Can you share a moment where something clicked for you clinically, an assessment or a treatment choice or patient education that really worked as far as what we're doing in skilled home health? It could be a test. It could be, different, the modified CATSIB, which is the balance testing, tug, 2-minute walk test. But what was a moment that clicked of how this test or what I'm doing can be broken up into these different areas?
Great question. I found out that during our evaluations, reassessments, one of the outcome measures that we've used is modified CATSIB, and that one in particular, it really did click for me. I think the first or second week of doing it, and having someone standing on the phone pad, being able to tell whether it was the somatosensory system being impaired, or was it the vestibular system being impaired, or their visual, are they visually, if they were heavily reliant on their vision, right? It really clicked for me at that moment. I learned from a tutor back during school that they're showing us how to figure out how to answer the question. However, now being here and actually looking at it and seeing where somebody's deficits may lie within the test that we're providing is an eye-opener. And it allowed me to see, okay, well, if their balance is impaired here, this is where we challenge them. And I found multiple times where I found myself in multiple scenarios and instances where the patient may ask me, what does this do? I've had a patient once before. We're sitting down and we stood up and I told her, listen, we're going to be standing on the foam pad in a little bit. Yeah. And she looked at the foam pad. She said, you don't expect me to stand on that, right? And I said, we're going to get to it. We want to see how your balance is prior to. I was very compliant with it. Enjoyed it that I was giving her information that probably is beyond what we need to educate, but it was the fact that she looked at me and I told her, I said, this is what we're going to be accomplishing here. And then this is how it's going to relate to real world tasks, right? Being in the house, being able to ambulate within the house, and being safe, understanding too, when they have to get up during the night and it's the lights are off and they're challenged visually, right? Being aware of their surroundings. So that's the moment where it really clicked, and seeing how well that patients respond to it and appreciate what these tests can offer. So I really enjoyed. That was my second, I said, my second week being here. That's when it really clicked. Okay, this is what home health is like, and not just home health, but therapy.
Yeah, therapy. Yeah, that makes sense. Because we're trying to form treatments and balance treatments that target their weak spots. And really any home health company, skilled home health, we're talking, not just, when you say home health, people think it could be personal care. We're skilled. So it's all skilled. But when you have patients with balance problems as therapists, clinical DPTs and PTs and OTs, et cetera, have to focus on what's making the patient's balance worse. So we have to always look at the patient according to their 5 systems of balance.
Yes.
And I think that's something that in our company, we make a structure of every clinician understanding what those 5 systems are. I'm not saying when you get out of school, when we hire clinicians, DPTs and PTs and OTs, they don't know this. They should. But if they don't, we make it known that, hey, if we're not going into the patient's homes every evaluation or every start of care and trying to diagnose or assess every system of balance, we need to look at their cognitive status, their musculoskeletal status, vestibular status, visual status. That all goes into it. Somatosensory. Those are your 5 systems. I just mentioned them right off the top of my head. So if you're not going in and you're not kind of assessing those 5 systems of balance, and then targeting the weak ones, what are we really doing? So I always say it has to start there. For the 5th thing, rapport with patients and caregivers. What have you learned about building rapport with patients and caregivers in the home environment? And then how does that impact the quality or their outcomes with the home exercise plan and everything else?
I think, that's a question where I've, and not to boost myself, I think that I've done a good job since being here to build rapport with the patient. However, it's understanding when you walk into a patient's house, right? Getting the feedback from the patient. What are the vibes, like we like to call it sometimes? What are they presenting? Because sometimes patients that you see, like if they aren't cognitively aware, they're not going to present with, even if you try to build good rapport with them, sometimes, behavioral issues may be present, but I understand too, just being able to build rapport with patients, being empathetic. We talk about balance, healing, empathy, and the art of caring, right? That's one of the Equilibrio's ways. I've understood being here that these patients are in need of our services, right? So when I've walked in with you, one of the things I always ask is, what are your goals? What's your goal for treatment? What can I do to help you, and what do you need from me, right? I'm not here to fix you. My goal is to assist you in your task that you want to improve upon, and going to the bathroom, whether it's going to the bathroom, getting up, walking up the stairs if they have stairs, and things that we know that they need assistance with. And I show that I care, and they've responded positively to that. So I think my personal way of going about building rapport with the patient is just being more personable. Sometimes it takes that. I know if you have a patient that's really trying to cut you off, those times you can find yourself in a certain predicament where it's tough to try to communicate with that patient.
Well, when you have patients that's a good point you brought up, because there are certain families and patients where they like to they want to kind of run the conversation, or they want to rule. You're in their home, and they're trying to dictate the way things. So there is a fine line between what we do as clinicians, and you have to be as a DPT and clinician in the home. You have to take control of, you respect their wishes. But you have to say, I'm here. The doctors ordered me to come out here to assess these, and so I like your input, but we're going to do it this way because I feel if we can find this out, and why that doesn't make sense to me. You can explain it to them, but that's where you have to build that trust. How do you build it? You just find common interests, whether it's fishing, football, or family stuff, and then try to tell them, I've got to look at this in order to get to this root, the root of what's going on here, right? So if I can find that, then I can definitely help. And then they start trusting you, because, like you said, they'll cut you off, and you're talking to them, and they'll be like, well, that's not the issue. I don't really want to talk about, my diabetes is fine. It's, even though the blood sugar is 220, I just had this morning a bunch of bagels or pancakes, and it's usually 85 or 90. Okay, well, that's not probably true, but that's them deflecting and making, because they want to focus on maybe just their exercise, and that's good because they help lower blood sugar, right? I'm just using this as an example, but maybe they don't want to hold dissertatum or a whole discussion on what they should be eating, right? And as physical therapists, we're not dietitians, but we can definitely say, I wouldn't have those pancakes this morning. I wouldn't have the cereal with the whole milk. Replace the whole milk with almond milk. I would try to use a low carb cereal, and educate them why that's important. And skip the pancakes, maybe just a few eggs, or if you're going to have a pancake, have half of one, and drink lots of water with it. And then watch how that should make their blood sugar better with the exercise and things we do. And that's why they may be more interested in listening to you. Whereas you just come right out and start trying to say, you shouldn't be, why are you eating this? They're not going to be as receptive because they don't understand where you're coming from.
Now, I just wanted to ask you a question too on that. Because I haven't had the scenario yet where someone, when we had a patient say, well, I'm going to just eat my pancakes, right? How do you work with that? I haven't had the scenario yet where a patient will tell me, oh, listen, I'm not going to listen to what you have to say. You're not smarter than me, so on and so forth. But what have you experienced to that?
When patients are defiant and say, I don't want to, I want my pancakes.
Exactly.
I've been having pancakes my whole life, or I've been drinking my 2 glasses of red wine every day. What you need to tell them is, I know you've had a way of doing things your whole life. I always say, we're here helping you, right? You were recently, most likely we're there because they were in the hospital, rehab center. There was a setback medically, right? So you handle it just like anybody that has any other issue, right? This is medically. It's not like they're addicted, or they could be. Some people live with addictions their whole life, but they're functional and they're good people, right? Their body eventually starts failing them. So in this case, maybe they're addicted to the carbs and just a bad lifestyle of eating diet. I always tell them the reason why we're here and you were in the hospital recently is not, I know you've been doing things your whole life, you're used to it, right? But I say, if you're we're here seeing you right now today because you haven't been an example of health and wellness for your body over the past 15, 20 years. Okay, so you've been doing this. That's great. You're used to it, but your body is now responding. And it's causing you major medical problems, which could lead to more hospitalizations and, the the worst case scenario is possible death or failure of certain organs. And I just say, you're not here. We're not here because you're on a winning streak right now. I guess that's the best way to put it, right?
Yeah.
So they might be winning in life, like as a good person. A lot of people with medical issues are great people. I'm not saying, but their just way of living isn't what the body needs all the time, right? So we have to marry the two. Now, there's a lot of people out there that are good, they're not good people that take care of themselves, and they're just they're not too good people. Like, so there's a fine line. You want to be, you want to marry the two, be good to your body and try to be good,
Right.
But in this case, most patients are not coming to see us from the doctor's orders or hospitals or rehabs because they're on a winning streak with their health and wellness. They've made bad decisions with their health and wellness, and they need us to refocus them, or at least try to help them understand how they can manage it better.
Okay.
And then we're there to teach them good habits, man.
Right.
So, but that's I like that. You just have to get them refocused on good habits.
Yeah. Yep.
Unexpected challenges. What's one challenge you didn't expect in home health, and how are you learning to handle it?
I think the unexpected challenge that I had, oh man, that's a hard one. I'd say, honestly, it's just being in the patient's house. Sometimes it's, you want to respect their wishes and you want to go in there and try to build that rapport with them. And I find it sometimes challenging to, honestly, we're trying to get patients that aren't cognitively aware. And that I found myself, it feels difficult to try to work with patients that do have cognitive impairments, because it's constant repetition, right? You want to make sure that they're understanding of their safety, right? And trying to get the caregivers involved, because sometimes caregivers aren't involved. That's what
caregivers aren't involved.
And that's when it's like really tough, where I've had a scenario where we went out one time and the caregiver wasn't available, and I'm like trying to educate the patient, but the patient's also not cognitively aware too. So it's just, and they're supposed to be present in that scenario or during our visit, and trying to give a patient that isn't cognitively aware or has cognitive deficits, exercises or these interventions that we're providing them. Sometimes, if the caregiver's not there, how are those dots going to connect, right? So trying to work with not only the patient, but the caregiver at the same time, and trying to educate them as well. Right. So I felt that, so going back to the question, making the hardest challenge the unexpected challenge that I faced being here was also being able to educate the patient and the caregiver as well, if the caregiver's around, and trying to work with what we have, because the patient, if we're seeing the patient in their house and they're living alone, for instance, that's a tough one, right? So I've come a long way in the last 5 weeks to work on that. And I think that's been my most challenging part of home health.
That's good that you noted that, because there's a lot of challenges in home health, but you have to have the right caregiver support in a lot of cases, because some patients just can't take care of themselves, or they can absorb, but they can't physically conduct their own exercise plan or what we're doing to help them. They need to have a family member, a personal care aide, someone support, like the gentleman that we saw with out in Norfolk, the Mr. A, we'll call him. But he's kind of not bedbound, but chair bound, and transfers, can walk short distances, but without the personal care aide helping him and his really supportive wife and the whole family setup there, he's been able to be at home now for many years and doing well. He needs consistent home health, but it's because we're able to keep him out of the hospital, decrease his fall risk, which internally it decreases expenses, because if he's not in the hospital, then it's less money to continue to have some home health helping him with physical therapy and OT needs than if he were to fall and have these setbacks and be in the hospital consistently, So I always say that we're a blessing to the healthcare system. I think skilled home health is a huge blessing to the healthcare system, because we decrease financial burden on other areas of the healthcare, which are the hospitalizations cost tens of thousands of dollars.
Mm-hmm.
Skilled home health visits, average LUPA rates between $175 to $200 a visit. So would you rather spend
Thousands of dollars,
$5,000 to $10,000 in a day for Medicare hospitalizations or not?
Mm-hmm.
Safety and decision making in the home. How would you approach safety and clinical decision making when you're walking into a new home health visit?
I'd say my biggest. So when I go into a patient's house, I look already off rip. I'm observing the environment to allow me to see, okay, do they have the appropriate walk space, so they can navigate whether they have a hallway or to go into the living room, the kitchen. What does it look like, right? So being able to see that and then administer, say, for instance, if we're putting an order for a walker, right?
Right.
Are they able to get into the bathroom and be able to navigate into the bathroom? And is the DME appropriate, right? So what I've noticed is that I've been able to, along the way, the last 5 weeks, is make those appropriate decisions of, I think you should use a rollator, or I think you should use cane in this aspect, because patients, they may not know that, and they're trying to figure out any way to get the task done, right? So giving them that education and awareness of, listen, I suggest you use whatever this equipment is to ensure your safety, and that you are able to appropriately, let's say, for instance, ambulate to the bathroom or up the stairs and to decrease fall risk, right? Those are all things that we need to educate them on, so that way they're still around their loved ones, right? We don't want to make sure we want to make sure we keep them out the hospital.
That makes sense. Yeah, that having the right things in the home to help increase their safety really does make a difference with proper grab bars, shower chairs, bedside commodes, set up properly. Just that's one big thing that we do when we go in. We're always looking to see is there the right equipment? Number one, the right equipment versus wrong is big, but also, is it set up right? If it's the right equipment but it's not set up right, it could cause a problem.
And
because patients will have the right idea. They'll research ChatGPT, set this up, whatever. But it's the ChatGPT may not be honing in on proper setup for their home because they're not in their home, right?
And
we need to have us actually be there live to see the situation. And
I noticed too, where patients will buy, let's say, for instance, a quad cane or a rollator from Amazon, right? That equipment will come in and it's not even set up, or they look it up on YouTube to try to set it up themselves, and they may set it up inappropriately. We had that one patient.
It's the wrong height.
Wrong height, or
switch the wrong way with the prongs or facing the wrong way. Just subtle different details, and that we're there to catch that. And that's a blessing that hopefully every clinician with every skilled home health company does these basic things. But I do know there are ones that just don't. They're even though they have the same degrees, we have some people are just sleepwalking through the day and doing with them, and you hope that's not the case. You know what I'm saying? When you have a healthcare need, right? I always say, let's try to treat every healthcare opportunity with someone we see as a patient as if it's your own family member, and you're trying to give them the best knowledge. And we all make mistakes. Mistakes are one thing, but just not taking your job to serious or how understanding the gift that we have to offer, because we all have a gift, man. It's our knowledge from school.
Yes.
USA, I know, prepares you guys tremendously.
Oh, they do.
They get you guys, everyone that comes here is super sharp with their knowledge-based skill set, hands-on, definitely with manual therapy. You guys are top-notch.
Yeah.
Kudos to the university for training you guys.
I appreciate it.
As we're getting down to the last few questions, mentorship and clinical reasoning. How has mentorship at Equilibrio shaped your confidence and your clinical reasoning so far, if anything?
I think what you guys have really helped me out with is communication. Right, that's one thing I've learned in the home health setting is communication's key amongst all the different. Like nursing, OT, SLP. PT, the communication between these healthcare professions is vital,
right,
to allow for proper care. Right, when
it's
you go
huge.
into a patient's home, right, do they need nursing? Do they need OT? Seeing what they need, that's really been one of the best benefits of being here, is seeing that we go through all these different we use all these different health professions to help with the patient's needs.
Yeah.
So you guys taught me how to properly communicate with not only the patient, but also amongst the other professions that we work alongside with. So, and you've been a big help to that too, making sure I'm also aware on top of these things so I can better myself as a future clinician.
Wow, that's our job is clinicians that have been in the field for several years, and in some cases 10 or plus years. It's just to give you the knowledge and insight that we've seen so far across different patient and home settings, and then how to handle it. But communication is always key, because if you can't communicate well, I always say it's better to be an over communicator than under, but there is a sense of over communication when it comes to what we do, because there is when our census grows, we have an app with Home Health Notify that allows us to talk, and that's where we need to hone in on important, concise details.
Right.
Because when you're communicating through an app system that's Medicare HIPAA compliant, you need to get right to the nitty gritty. You don't have time on there to send along, like I can send long text messages to friends and family, but there's friends and family type talk and texting, but then there's the text information for healthcare professionals needs to be patient has a quad cane, there's a dog in the home that could bite, go in the back door,
precise and concise.
Precise information, not that they live in a 5-story house and they've got, that's all. We don't need to, I'm sure when the person goes there, they can see what kind of house they live in and all that, but what's needed to know to make the visit go successful. That's about it, really. And so we communicate really well. We communicate things to help clinicians have success and set them up for success every visit. Misconceptions. So what are the misconceptions about home health care? What's one misconception people have about home health or about working with older adults that you'd like to correct from what you've seen? Or if any, there may not be any that you see.
I don't think I've seen any, to be honest. I think that honestly, being here, you're going to get a wide variety of patients, right? With different diagnoses, different ages too. Typically with 65 plus, but the thing is, you treat them the same. You go and work with them, show them empathy, good compassion, and you try to implement those good clinical skills and decision-making skills to allow for a proper treatment. But I don't think I've had any misconceptions about health since I've been here.
Great. Yeah. There might be some students, maybe when you go back, try to ask your fellow classmates and students that have not had an internship yet in home health, and just say, just out of curiosity, what do you think skilled home health is like if you were like you as a physical therapist, and see what they say. It might be eye-opening, because they might say to you, they might give you some answers that are kind of like way off base, and you'll be like, oh man, you're totally off. I've just finished one, and this is what, or they may say something to you that's pretty close. You'll be like, yeah, that's pretty good insight, because I just did one, and you're, it might be a good to do that, because it might test their overall knowledge.
Right.
But just ask if they're willing to give you some, feedback. Because if they've never, you want to talk to people that haven't done it to see if they've researched it, or what maybe they just have a stereotype.
What's their opinion?
Yeah. Oh, I heard home health's horrible. You got to travel everywhere to go see patients. They may not be home. You have to do that Oasis.
Oasis.
And then you could tell them, well, you're right, there is some more, but the artificial intelligence scribe system that they have now available helps.
Right.
So there's so much technology supporting our field of what we do in skilled home health. It's really making our jobs as clinicians easier. So it allows us to show how great of clinicians we are. We can just unleash the gifts that we've got,
right,
and then let the technology part aid us.
Yeah.
All right, now we're down to the last two topics or questions here. Innovation in home health. How do you, and we've already touched on some of this, like Notify and Scribe, artificial intelligence scribing system to help document. How do you see innovation fitting into home health? Anything you've seen at Equilibrio that stood out, like technology, workflows, patient education, or our specialty programs, maybe even modalities that we use, like the cloud device or the beamer with the bioelectric magnetic energy regulation or things like that.
I definitely, since being here, I think Scribe has been one of the best things.
Yeah, everyone likes it's been the scribing system.
It's been very helpful. Understanding too, there's technology is technology, right? So technology can be wrong, it can be right. You have to make that judgment on how to, if you will need to change it, you can. But the Scribe, it's been wonderful, especially with documentation. Seeing when you have a 45-minute visit with a patient and you're trying to get in all that information to do, like, let's say for instance, the Oasis, right? That's a lot of information that you have to put in that within that documentation.
It is. It's a lot. But
being able to use Scribe to help me basically remember or go back to see what we did, it really has helped me improve my documentation skills, along with, which is one of the goals I had from coming here.
So one thing I want to piggyback off your answer with Scribe. Would you say using the Scribe system that we have allows you to better stay on task when you're doing your evaluations or assessments?
Yes.
Why so? How is that? Because I tell clinicians, if you're scribing and having to talk out what you're doing, because that's how you get the good information to get into your note. To me, using the spoken word is easier than typing or writing. Once I voice to text was the best invention of all for me, because it's so much easier for me to voice out. That's why people say, why are your texts so long? Well, I just spoke this out and I text. But at least it gets my thoughts out clearly, right? So when you speak it out and you can go through your evaluation or assessment saying your muscle strength grades, the scores on the test, but also allows you, as you're saying it, thinking through what you just said, you can recorrect yourself if you need to. You let patients know I'm going to be talking out loud. So they don't understand, so they know, and they can see we're recording what we're doing.
I think, with Scribe, it's been very beneficial, especially with the objective measures, right? And subjective too.
To get details.
That gets the details. Right, and even when we've had multiple scenarios where we had a patient one time where they had a 100-year-old cane, right? And they picked it up. So, but it's like understanding too, like making sure that Scribe has been very beneficial in that aspect where it takes down all the information that we need, our subjective, objective history, along with like the assessment piece. And so it's been very organized. And I think when you go into your note and typing up everything without Scribe, you had to type up everything and try to remember all the stuff that you did. I mean, obviously you're going in and during your initial evaluation or your PT visit or reassessment, you're jotting notes down as you're going through. But with the Scribe app, it's been very beneficial to see how it takes all that information that we did in our visit, puts it in a structured format, so that when we go in to do our note, the information's right there, right? And now if you need to add some little nitty-gritty stuff to make sure that it's more clear and concise to what you're trying to relay, so that the next person that does see your note can follow, then so be it. But it definitely is the new wave, I should say. I love it.
The new wave of documentation, and make sure your clinical work is factual and it stays very accurate.
Right.
Yeah, that's a good way to look at it. Last question. So what's next, Nahshon? Looking ahead, for you, what kind of clinician do you want to become after this internship, and what's the biggest lesson you'll take from Equilibrio Home Health from this internship experience? It's your ICE, which is your initial clinical experience.
Yes.
And we're thankful to have you do your initial clinical internship with us. Usually it's hard because you haven't had any hands-on in home health. You get thrown right into it.
Yeah.
But I get that for you, it's if you're already ready and they prepare you well, it makes the rest of your internships really easy, I think, because you intense documentation here, really diverse clinical cases in the home that you're never going to, you may not see in outpatient, but in hospitals and rehabs you will.
Yeah.
So it'll prepare you for that. So,
right. I think what's next for me, well, I got two more didactic terms before I go on the last two rotations. But Honestly, just finish up school. I think I'm not quite sure yet where I'm going to be headed. Home health has really opened my eyes and has shown me a different perspective. Going into it, you don't even know, right? I think, like I told you about this, when during school they don't talk about it so much, like compared to your skilled nursing facility, inpatient, outpatient. But home health is very beneficial, right? And like I said, that home health has allowed me to understand more on how to build my rapport and my communication with patients, and then actually seeing what the house and the environment they live in, right? Because asking for that an inpatient, you don't truly know what the house looks like until you're there. You don't. This is what being in home health, it allows me to have access to all of that. I love this experience. I enjoyed my time being here. I got another 4 days to go.
Yeah, just 4.
But
that's right.
Yeah, in terms of what's next, it's unknown as of right now, but definitely looking forward to potentially doing home health in the future.
Sometimes the unknown is great though, because you take the knowledge you've gotten, which you do know, and you take this experience and you don't know what lies ahead, but you do know you can rely on the education, the experience you've gotten for unknown opportunities, and then you can take whatever one you like. And the good news is put this in your tool bag. You might want to work in home health when you're done school. Home health, you might want to do some PRN work with it. You might want to do it full time somewhere. You might want to move back to this area if you like it. So, we're glad to have you, and glad to have your passion and your energy and desire to want to help our patients. And you've really made a big difference with a lot of them, and that's why we have this. We're so thankful. We're blessed to have this opportunity with these students, man. I just want to say, and I'll say the same thing to our next DPD student I'll be talking to in a few minutes. But it's been a pleasure to have you, man. Yeah. So wish you the best.
Thank you very much
for being with us, and to our followers and all of our listeners and supporters out there. You can always follow us on the Equilibrio Balance podcast series on all of our social media platforms. You can get more information from our website at www.equilibriohh.com. And if you have any clinical questions, you can reach out on that website to ask them, or reach out to our local corporate office at 757-965-9942 on skilled home health care needs for you and your loved ones. Thanks for tuning in today, and everybody have a blessed, great day, and we'll see you on the next episode. Thanks.
Right, thank you.
Thanks for tuning in to Balanced Care Conversations with Equilibrio Home Health. If you found value in today's discussion, be sure to catch our next episode on Spotify, Apple Podcast, or wherever you get your favorite podcast. For more innovative healthcare insights, detailed resources, and the latest in skilled home healthcare technology, visit us at equilibriohh.com. Until next time, keep striving for balanced, innovative care solutions that make a difference. Remember, the future of healthcare starts at home.